Hello, everyone. It's 21st of November 2024, World Pancreatic Cancer Day, and we're delighted to be hosting this webinar for you. We feel it's very important because pancreatic cancer is really a cancer of unmet needs for many reasons, not only because it's difficult to diagnose, difficult to treat, the survival statistics are a little bit difficult to handle, but it's associated with very difficult symptoms. And I think that's one of the reasons we've come together today to discuss an approach to one of these complex syndromes of symptoms called cachexia. And we've got a great lineup of panelists here today who will go around, so we can ask them to introduce themselves. But just a couple of housekeeping things. First is just I'll ask all the attendees just to use the question and answer box for submitting any questions, and we'll answer them as we can. We've had many questions already submitted to us, so we may actually have our kind of entire webinar full and just answering those. And thanks to all of those who've submitted them from across the UK and also US and further afield. So without further ado, I'm going to ask people to introduce themselves in turn. I'm Bristi Bassi. I'm a medical oncologist who works in clinical research trials in early phase clinical trials, especially for pancreatic cancer patients in Cambridge. Tobias, could you introduce yourself?
Good morning, Bristi. I'm Tobias Janowitz. I'm a medical oncologist specializing in pancreatic cancer treatment, and I also have a research laboratory where we research the condition that we will discuss today called cancer cachexia.
Thank you. And the reason that Tobias has said good morning is because he is actually in the United States. Tony.
Hello, good afternoon. My name's Tony Coll. I'm a diabetes physician here in Cambridge, UK. Still practicing a lot of diabetes medicine, but also with a research interest in the control of body weight and body composition, and working in a consortium with several of the members here of the panel to see if we can understand a little bit more about the causes and consequences of cachexia.
Fantastic. Julia.
Hello, I'm Julia Biffy. I'm a junior group leader and at the Cancer Research UK Cambridge Institute, and my lab works on understanding cancer cell, non-cancer cell interactions, also in the context of cachexia and pancreatic cancer.
Nicola.
Hello, my name is Nicola Day. I'm a clinical specialist physiotherapist in oncology, rehab and exercise, and I'm based at Adam Brooks Hospital in Cambridge.
Thank you. Laura.
Hi, I'm Laura McGeaney. I am a dietitian and I've been with the Pancreatic Cancer Service at Adam Brooks in Cambridge for the last 13 years.
Thank you. Richard.
Good afternoon, everyone. My name is Richard Skipworth. I'm an upper gastrointestinal surgeon by trade up in Scotland and a long-time researcher in the clinical and translational aspects of cancer cachexia. Nice to be here.
Thank you very much. And Jenny, who has unfortunately not got a voice today, but she will be behind the scenes answering questions, typing up links. And Jenny is a specialist nurse at Pancreatic Cancer UK. We're very lucky to have her because she's got considerable experience in getting referrals from across the country for this important condition. So why don't we start off by trying to describe a little bit about what is cancer cachexia and how does it differ from other kind of weight loss conditions? So maybe we can start off with Tobias and maybe bring in Richard and Tony into this discussion.
Yeah, thank you, Bristi. I think for the people who are dialing in, patients and relatives and those who have been in touch with patients with pancreatic cancer, the easiest way to understand cachexia is through the symptoms and signs that the patients are experiencing, which are a combination of an involuntary weight loss, so weight loss despite efforts not to lose weight, and coupled with an inexplicable loss of appetite. So not feeling hungry, even though one is losing weight. That's a classic way of experiencing as cachexia. And then the consequence of that is a weight loss that becomes disabling, so people find it more difficult to ambulate, they are less mobile, they may feel less motivated to do things, they have less strength. And that's really the consequence of this weight loss and the loss of appetite. The formal clinical definition is a weight loss of more than 5% over the preceding 6 months. But that's really capturing what I've just said, what patients are experiencing.
And Tony or Richard, could you kind of let us know why or how it differs from other conditions where you see weight loss? Is there anything much known about?
Right. Shall I add something to that, Christy?
Yeah.
I think it is different from other issues with weight loss. And I think as my role as a metabolic and diabetes physician, we often have people who are trying to lose weight to improve their health, improve their metabolic health. And I think many people will be aware that trying to lose weight can be very difficult sometimes, and is often you have that reaction of having hunger. But occasionally, when you do actually lose weight, when you have a metabolic condition, you actually feel better. And what Tobias is saying is that what we're trying to understand here with this cachexia syndrome is that the weight loss is effortless and without any conscious input. You don't have that compensatory hunger, and actually you don't feel better, you feel worse. So there's that apathy, that loss of volition, that loss of being able to feel that you want to be involved in anything, which I think is very different from that weight loss that perhaps I've been used to historically in trying to get people to lose weight to help their metabolic health. This cachexia weight loss is adverse and is associated with adverse outcomes.
Yeah, and maybe does anyone know why we see it with patients with pancreatic cancer? Is that something that's known about, or is that something we're looking into at the moment?
Shall I take that one?
Yes.
I mean, I think Tobias and Tony have summarized it very well. The the difference between cachexia and weight loss through simple starvation is that somehow this weight loss is due to the product of the presence of the tumor within the body, rather than someone simply not eating. And this is because we believe that there's some interaction that is taking place between the presence of the cancer and the presence of the patient's body, which is causing, in essence, an abnormal metabolism within their body. The tumor is secreting several molecules and mediators that cause this to happen. One of those is inflammation. And so one of the other ways of defining cachexia is by assessing the presence of both weight loss and inflammation simultaneously within the blood of the patient. Now, this constellation of mediators and molecules that take place is very complex, and I think that's the area in which a lot of us on this call are working.
Great. Okay. Well, maybe in that case, you could let me know if you feel that cancer cachexia is inevitable for patients with pancreatic cancer, or is there something that really does separate the patients who get it and who don't get it? Is that something we know about?
Well, I can start to answer, but I think that that's a very complex question and that other people will probably want to wade in. There is no doubt that there probably are differences in terms of how cachexia presents itself between different types of cancer, between different stages of cancer, and between different aspects of the person who has the tumor, including things like their sex, their age, and actually also their genetic predisposition. There is some evidence that some people might have some certain genetics that make them more likely to develop weight loss in the presence of cancer. So there are things that may be associated with triggering it. There are also things that can occur as the consequence of the treatment that they get to the cancer. But as I said, there's quite a big answer, so I'll let others contribute as well.
Maybe Tobias, I saw your hand go up.
Yeah, thank you. I want to say something which is, I think, important to say for the listeners who are dialing in. It is not easy to overcome cachexia, or it is actually, to our knowledge, not possible through volition, through effort, and through the patient or the relatives trying to say, we are now going to do something about it, and it gets much better as a consequence. I think that's really important, because when I see patients with pancreatic cancer, and I'm sure you do as well, who lose weight, they often wonder, what can I do differently, and am I to blame that in addition to having the cancer, I am also losing weight and am withering away, and my relatives feel that they need to feed me more, and there can be a lot of suffering as a consequence of that. And the way that we are beginning to understand this condition is that it is truly something that has a molecular mechanism underlying it that drives this condition, and that it's very difficult to not want it and thereby cure it. And that is seemingly impossible, actually, that there is a profound biology that drives it. And the efforts that we are all making are to understand that biology so that we can get to the switches that happen, that switch this condition on, that we can switch them off or at least tune them down.
Okay.
And so that we can make patients feel better.
No, thank you, because I mean, I think, that's an important aspect to understand what the research is telling us about the biology, but also maybe not to have a nihilistic approach, because it sounds as though you could be nihilistic about this, but maybe later on in the webinar we'll address ways in which people can try and address ways to help themselves, even in the absence of any trials or medications or research. But so we'll I'm sure we'll head through to that. But perhaps Tobias, maybe yourself or others can tell me how cachexia actually affects your recovery or the way you kind of approach or react to your cancer treatment, if you're aware of this, of any kind of data or anything else in your own clinical practice.
Sure, I can make a start at least, and then I think Tony and Rich might be able to come in. So one of the things that is important to realize is that many of the treatments that we give to treat the cancer are complex treatments and are treatments that are asking a lot of the patients in their own right. And as you can imagine, if you get, say, a chemotherapy that has multiple agents in it that might work to tune down the cancer or even to kill the cancer cells, it is also a treatment that affects the whole organism. And if the whole organism is already weakened by the effect of the cancer, then that becomes more difficult and more difficult still. And so one of the reasons why we are interested in making patients with cachexia better or preventing cachexia is so that we have a better opportunity to treat the cancer.
Okay, great. And having treated the cancer, you feel that affects the modulators that Richard has mentioned, the approach and the ability to tolerate the chemotherapy or other interventions. Is that
Yeah, I certainly feel so, and I hope there would be almost consensus about this, that ultimately the causative aspect is the tumor and the progression of the tumor. And if you can, so say, for example, if you were able to cure the cancer, there would be good evidence from the cases that we have and also from the preclinical work and model system that the cachexia will also resolve.
Okay, very interesting. And just to highlight to the people on the call that the organism we're talking about is the human person in front of us. Clearly, we're trying to approach this from a holistic point of view, and kind of realizing that the cancer in itself in isolation is not all the only thing we treat here. Is the patient around the cancer and how we improve the cancer, and also their outcomes from treating the rest of their condition as well. So I think maybe it's a good kind of time to look a little bit more closely into what we are understanding from research, what research efforts there are. And, I feel like from my point of view, it seems like a very exciting time for research in this. It feels like a lot's going on. So I was thinking if we could separate this into the lab, the preclinical, and then the translational, maybe sampling, and then maybe the clinical approaches, what types of drug trials and things like that. So maybe should we start off with the lab and the preclinical kind of models and things like that? But Julia, do you mind starting us off with what's happening out there so that our listeners are aware?
Well, sure. So there's a lot of focus now in trying to understand the causes and mechanism of cachexia and identify some of the mediators and factors that Richard also mentioned. I think the great thing is that we have across different labs, they developed a number of models of pancreatic cancer that develop cachexia. And so this allows us to understand what factors cancer cells, but also non-cancer cells that contribute to the tumor progression are contributing to the development of disease. So this is one aspect. But then on the other end, this allows us to test potential treatments in these models and evaluate whether they can be used to prevent or reverse cachexia. And then the important thing is that we are learning from the patients and trying to model this in our lab. But at the same time, our better understanding in the lab is then brought back to the patients. And so there has to be this continuous back and forth between the two.
Brilliant. And I think there are huge efforts here, especially transatlantically. I know that you're involved in some collaborations here. I was just wondering whether you were happy to say anything about these collaborations, Tobias or Julia, just to kind of, so that people are aware of what's going on currently.
Yeah, so maybe I can start and then Tobias can comment. Actually, on this call is 3 of us, part of a much larger team that is comprised of several institutions, both within the UK and the US. So both Tony, Tobias, and myself are part of a Cancer Grant Challenge team that's funded by the NCI and Cancer Research UK. Tobias, one of the co-leads, and he has recruited me and others to this challenge to understand several aspects of what causes cachexia from different angles. So my lab is trying to understand how these non-cancerous cells and cancer cells are contributing to this. Tony can comment on what his lab is doing specifically as well.
Tony, do you want to just take over from there?
So yeah, I'll pass on to Tobias next, but I guess we're coming from this from a slightly atypical, but I think probably informative way. And our laboratory here in Cambridge has spent many decades trying to understand how we choose to eat, what the drivers of our appetite are, and how different organs in the body share nutrients and build themselves up and break themselves down. And it's complicated. Organs talk to each other. And I think what some of the very strong trends that we've got through our research on obesity and other studies of metabolic diseases is just how important the brain is in trying to integrate signals from various parts of the body to then make changes into fat stores and muscle stores. And being, as we've already heard, quite a big driver of the cachexia syndrome, if you like, is that loss of appetite without that drive in hunger. We're thinking, at least in part, some of that must be mediated through the brain. So we're really excited about trying to understand quite a bit more about how signals coming from cancer cells, talking to other tissues in the body, being orchestrated within the brain, and bring about some changes in meaningful areas like muscle mass and fat mass, so that people can live well and be able to respond to those essential therapies which are actually targeting the cancer themselves. And I think there is, before I hand over to Tobias, I think there is hope that will be a fruitful approach, because that's worked in other disorders of body weight and appetite. And we hope that what we've learned before, we can bring into focus in this particular arena. So Tobias, I don't know if you want to add more.
Well, I just want to tell the listeners it might be on a World Pancreatic Cancer Day, surprising to them that, we are researching hormones that control appetite. But what we really have realized is that there are unifying aspects to cachexia, and cachexia is not unique to patients with pancreatic cancer. They are often affected by it. And one of our driving motivation to research this is because patients with pancreatic cancer suffer from it so frequently. But there are other conditions, lung cancer and other cancers, where it is common and where it takes a similar pattern of disease, almost to the degree that we feel it is the same condition and the underlying cause can sort of subtly differ, and it doesn't matter if it's lung cancer or pancreatic cancer. There are even some non-cancerous conditions that can cause cachexia. And what we are really trying to understand is what are the unifying principles of this condition, so that we can identify the mechanisms like Tony has alluded to. And what we realize is that perhaps it would be best to have a team with many different expertises that come together to try and make inroads into that. So we have individuals who study model organisms, who study how nutrients are being processed and divided in the body. We have people who are hormone experts like Tony, and we have people who are clinicians. And then we have even epidemiologists, so who look at the large scale. Coming back to the initial question that you maybe asked, does everybody develop the condition? Do some people not develop the condition? What can we learn from the population in order to inform our research?
Yeah, and Richard had mentioned something about inflammation before as well, and I'm just wondering what we are aware about the role of inflammation, or what's cause and what's effect. Do we have any understanding of that?
Yeah, maybe I can make a start and then Richard could follow up. So you could think about these molecules that are caused in the tumor and the tumor microenvironment that are due to inflammation to get into the circulation like hormones. So they leave the tumor, they get into the circulation of the blood system, and they act everywhere else in the body where they can be perceived. And they can act on the brain, for example, and change motivation or appetite. They can act on other organ systems. And I think one of the ways by which we look at this is, do these inflammatory molecules switch on these switches, on-off switches that I was referring to, in different organ systems to orchestrate a response? And my lab, for example, focuses on the effect on the brain and on the liver. And Richard can maybe speak to the effect on the muscle, where he has made major contributions. And so we are trying to pass this all together. How does the puzzle come together of the multiple organs that are being affected?
Richard?
I think Tobias has summarized it very well there. It is a multi-organ problem and a multifactorial problem. There are lots of things going on at the same time. In terms of inflammation on the muscle directly, we believe that inflammation is one of the things that actually drives muscles to waste over time and to basically shrink and become poorer in function. And then, unfortunately, affecting the patient in terms of what they can do with their functional ability, living around the house, their quality of life, looking after themselves and looking after their family. So it's a nice idea that we're trying to package this all together and look at the ways all of these things are grouped. One of the challenges going forward in terms of what you've talked about in the translational work is, I think, Tobias has talked very nicely about how there are probably unifying streams that affect everybody who has cachexia, irrespective of what the disease type, but there are also subtle differences between each one. And we're trying to find the things that cross all of the streams and also the things that are individual to each type of cancer process.
Okay, so if I were to kind of come up with a question, because maybe listeners hearing some of what you're saying say, well, if inflammation is felt to be important in this whole body kind of response, why not just have an anti-inflammatory? What about some simple drugs? And then why don't we discuss more complex drugs, perhaps? So can we have any discussion about the sort of drugs we've been testing in clinical research, or even any associated data which might suggest what might be useful medication-wise? Are steroids useful?
I can start. Well, steroids are used quite commonly within oncology, as you know, Bristy, and they're used basically to try and improve how somebody feels and also to improve their appetite, and can be associated with patients feeling less sick and putting on weight. They tend to have an effect for a period of time and then not necessarily last for months and months. There are a number of trials that have looked at anti-inflammatory products. And some of those anti-inflammatories, simple things like ibuprofen, have shown some benefit in terms of weight gain. But some of that weight that's been put on is things like fat. And perhaps fat is not as important as putting on weight that includes things like muscle, because muscle can actually help the person in terms of these quality of life and issues and looking after themselves, as we've discussed. There are some nice trials now that have looked at multimodal mechanisms of treatment. So that means exercise, extra nutrition, and an anti-inflammatory. And some of those results have recently been published and are potentially showing some improvement. And perhaps more recently still, there has been a randomized trial of an anti-inflammatory product against a specific molecule called GDF15. And that has shown that it has been able to put some weight on in patients. It has been able to show improvements in appetite and physical activity. And we're looking forward to the bigger studies that may be able to try and prove this conclusively.
I'm going to just bring this on to Tony, because I know the subject of steroids and things is a little bit contentious, isn't it? And from your hormone expertise, whether you've got anything to add to this discussion.
Thanks, Lucy. No, I think it just reinforces what people have said before. I think what that complexity is very hard to try and target, and because I think steroids and their target for steroids in so many different tissues. When you make something better in one part of the body, you can sometimes make things worse than another. And one of the well-recognized phenomena, I think, of being on steroids for a long time is it does tend to thin your muscles down. So whilst it might in some areas do a good thing, in another it may do something which is adverse. And I guess just picking up on what Richard said about GDF15, this peptide that comes out from a whole range of different tissues, but certainly goes up in a number of different cancers. What is perhaps a bit more exciting about that is that there's a much more finite receptor. It's a smaller target. So if you can hone in on that, you may be able to do a bit more good without the wider side effect profile that perhaps steroids have been that have run into in the past. Because there's so many targets for steroids, you end up hitting areas that are causing adverse effects while still doing good in other areas. So trying to get that precision, I think, is I think what we're all trying to do, and get back to what Richard said about, yes, there's commonality, but what if we can match treatment to what is happening in an individual, and that would be really exciting.
So interesting you talk about precision, because often we talk about precision in terms of the molecular phenotype, the genome, and the genetics of people, and targeting that within the cancer. But here you're talking about the precision within a holistic approach, and how you actually try and target smaller and smaller kind of areas, which might have less of the kind of associated side effects from the kind of the steroids, which we know are commonly prescribed and actually do help people feel a bit better. But actually, I think it's very important to bring out that discrepancy between weight. Is all weight good for you? Fluid weight, muscle weight, fat, and maybe this is something that Laura and Nicola can come back to either now or later. I mean, I'm very happy to open it up to you now, if because I suspect that's probably one of the real issues that people come up to you with, and for certainly it's such a stressful area for patients and their relatives when they're just losing weight in front of your eyes. And I'm just wondering, how these patients present to yourselves, Laura and Nicola, and how you offer them advice on maintaining weight of the right sort of weight.
Yeah, I think it's really important that we don't get too hung up about what the scales say. It's quite a dietitian thing, or doctors, we don't want you to lose weight, and it's something that we can easily measure. But like you said, you measure fluid, you measure fat, you measure muscle, and they all, would show the same change on the scales, but not the same for the person who's experiencing them. So we're trying to move a lot more into functional measures. So how far can someone walk? How easy is it to go up the stairs? There's like a sit to stand test. So like, how easy is it to stand up, and how many times can you do that within a defined amount of time? And these kind of measures are more useful. And like Richard mentioned earlier, there's been a really good study that has shown that the combination of specialist dietetic input, specialist physio input, and fish oils has helped for people over a 6-month period of chemotherapy to actually gain muscle. So they looked at CT scans as well as the function of muscle, and showed that people some people actually became stronger during this time period, which is not what we'd expect from 6 months of chemotherapy normally with pancreatic cancer. And like we were mentioning earlier, I totally agree that turning off, sort of killing the tumor kills the cachexia kind of thing, but sometimes the treatment for that is so toxic to the body, to the host, that they can't tolerate it, and so we can't get to that stage. So we really need to do these in tandem, and a lot of the work that Nicola and I do is about supporting the person, the host of the tumor, to go through the treatment of the tumor.
Thank you.
And so it's really important. One of the things that makes pancreatic cancer different from some other cachexias is the variability with the digestion, because that's where our digestive enzymes come from. And that has been a challenge, I suppose, in interpreting some of the research also that's been in the area, because either it hasn't been reported on, or it hasn't been used in the treatment of people. So we just need to bear that. And that's one of the things that we would do as dietitians. We would help people to have these artificial enzyme capsules to be able to digest what they've eaten and give good advice. But I feel I've talked a lot, and Nick, I'm sure, has.
Yeah, Nick, why don't you come in, and then I might come with some more questions to Laura shortly after that.
Yeah, no, absolutely. I think again that there's the knee-jerk reaction that patients have been told that there's muscle wasting going on, so their default is right. Okay, we need to try and build muscle, and the exercises that are needed to do that can be quite daunting and quite intimidating for patients. Actually, our primary aim as physios is to try and preserve the muscle mass that they've got, and more importantly, to try and improve their physical performance and functioning. So Laura's right. We're going back to these functional exercises like what's their ability like to get in and out of a chair, up and down the stairs, to do a walk over a short distance, etc., etc. So yeah, and trying to reduce physical inactivity is often our first port of call. We try and look at that patient much more holistically, and I know you're kind of going to come round to this later on, and I can give you a little bit more guidance about how we might start that and approach that with an individual.
Absolutely. No, I mean, and just to mention that we've previously had some podcasts and webinars done, and so there are some resources to access if you are interested more in kind of how you keep fit with pancreatic cancer and manage some of these additional symptom burdens. But I'm very interested in some of these additional metrics that we use to kind of assess your functional status, because we obviously in clinical research use things like survival statistics, time to kind of progression of the cancer. And so some of these additional metrics are kind of very useful, and in terms of your measuring skeletal muscle mass, your ability to walk upstairs or do functional things. So I'm just interested in how patients have been helping maybe to input into some of these metrics, some of these things which actually show if there is a difference from any of the interventions. Is anyone able to kind of tell me about this? 'Cause I'm not quite sure what the research is in this area. Maybe Richard, is that something that you're aware about? The kind of beyond survival, beyond weight, beyond or anyone else is these other kind of metrics? Yes.
Absolutely. These it's a really important question, Bristy, and it's a very complex answer. Unfortunately, there are these sorts of metrics that we use in clinical practice in terms of how they're seen by specialists like the dietitians and the physiotherapists, and the metrics that are used there. And there are also metrics that are used in clinical trials. Now, sometimes they don't fully add up with each other, and that is partly because we don't entirely know. We know which metrics can help us assess what somebody is like now. We don't quite know what metrics are good at being able to measure change over time. And when we're doing a clinical trial, we need to be able to demonstrate improvement over time. And some of these, you've described a lot of the metrics that exist. There are metrics of muscle strength, muscle power. There are metrics that look at patients' quality of life. When we do a trial, the people who authorize drugs are looking at improvement in 2 out of 3 things. They want to see improvement in the form, the feelings, or the function of the patient. And the form means things like their weight and their muscle mass. The feelings means things like their quality of life and their appetite. And the function means things like these sit-to-stand measures, stair climb power, 6-minute walk test, or the use of physical activity meters, which is becoming more and more popular. You need 2 out of 3 of those things to get a drug approved. And we're able to show quite easily that we can improve 1 out of those 3 things. We find it difficult to show that we can improve 2 out of those 3. And that means that we need to do more research in terms of what are the best measures to use in our trials and to assess our patient.
Yeah, very, very important. And how important it is that these measures are really relevant for the patient, because I think we all, as clinicians, certainly we all see data which says something is statistically significant. is it biologically relevant or relevant to the patient? Is it going to make them feel better? And that's actually something really important, I think, that we have to kind of keep having at the forefront, is how does it impact the person in front of me, the person I'm caring for, or myself, if I'm suffering from it. And I think that's really important. And actually, it's interesting to, work out whether patients with the lived experience of cachexia have contributed to some of these questions, whether they've been well enough to contribute to some of these questions. I don't know how many of the research efforts are involving the patient voice in this sort of field.
I think they do, and they increasingly do so. But I think those who've dialed into the seminar, and if they want to spread the word, we are always keen to hear from patients and their relatives if they feel that there are areas that are underappreciated by the research community. We actually, in our groups, for example, try to start off in no small part by asking patients at large scale, how do you feel? What are the key symptoms and signs that you are experiencing? And we do this in two ways. We have structured questionnaires where we sort of guide their answer a little bit by saying, do you experience loss of appetite? Are you tired? And sort of where the symptoms are predetermined, if you wish, and they rank how severely they affect them. But we also have open questions where we say, what is it that is of most concern to you? And then that is very helpful. And I think research endeavors in that way include patients and patient advocates more and more, because we do know that the actual most relevant questions, and sometimes also the tractable questions, are being asked by patients.
Okay, yeah, very good. So I think, we're coming to the last 10 minutes of this webinar. And so I thought maybe what we could go more towards is this patient question, because, this has been a fantastic, fascinating kind of research focused. I think it's very useful for people on this, listening to this, to know that there is, specific hard endpoints that are being tested. There's so much research going on in different fields. And I suspect that, maybe patients are not always involved in clinical trials. And we need to kind of get them more involved in clinical trials if we can. But perhaps I can kind of take this back to the patient in front of you in clinic, or the person next to you who is suffering from cachexia. If they were to come in, how would you start to approach managing this? Because they're often associated with, or come in with, a very, very stressed carer or family member who's been trying to feed them and give them their favorite food. And how do you approach it so that they can manage this safely and feel that they are helping themselves? Laura, do you mind just starting the ball rolling with this?
Sure. I think one of the aspects that's quite important is to explain in a manageable way what cachexia is to people. I think most conditions that we treat people for, we explain what they are first, and sometimes cachexia isn't sort of delivered in the same way. And like was mentioned earlier, this is not this is so weight can be, and how someone looks and the changes to their body can be very emotive. It's a very outward sign that someone's not well, and that things are changing, and that's obviously really emotional for those people that care for that person. And sometimes explaining that this is complex and that this is a metabolic condition, and all the sort of aspects of that's going on can help people to understand, as well as explaining what we can do to, even if we can't sort of remove the cachexia or reverse the cachexia, that things like physical activity, like good nutrition, like having the digestive enzymes, can make a difference. And kind of the positive side effects of something like that are that someone can feel stronger, that they can feel better in themselves. So there's not the kind of toxic negative side effects that there are with some other things, and managing other aspects. So there's a higher incidence of depression in people with pancreatic cancer. So supporting that and the emotional needs of people and their families is important. It's really important. So one of you asked about sort of when someone comes into clinic, and it can be, we give and we love with food. Humans do that. And relatives can't give chemotherapy, they can't perform surgery, they can't give other medication, but they can give food. And that's the aspect, how sometimes people are showing their love. And when that's rejected because someone has cachexia and they're just not able to take it, that can be really difficult. So sometimes acknowledging that and explaining that to a family member can sort of dissipate some of the problems there, because you don't want that to become an antagonism. Particularly if someone, say, was first diagnosed with diabetes and they were told to follow all this healthy eating information, and then actually the cause was pancreatic cancer, and that's all changed, but they've spent 6 months on this community programme to learn healthy eating and sort of been beating themselves up because their sugar levels aren't coming down. There's quite a lot to unpack there to give someone useful information.
Thank you for that. That's actually very important and extremely, something that we do see frequently. And it's very important not to feel guilt or blame or anything like that, because this is such a complicated condition, as you said. Tobias, I think you had your hand up. Did you want to add to that at all?
I didn't have my hand up, but I would like to say maybe a word in how I approach it. I think what Laura has just illustrated is how valuable it is to have many people come together when we look after patients in this situation, and to sort of, from the surgeon who may have done the original operation to the oncologist who sees them in the moment, to the team members, the dietitians, the physiotherapists, who can all make contributions in their own way to make the patient feel supported, but also to actually support them truthfully, not just to give them reassurance. The direction that I most commonly take is the idea of how can we balance the anti-cancer treatment with the whole body effects. And so what can we do realistically that might lead to an improvement in the cancer condition, and thereby should also lead to an improvement of the general health of the patient? And at what expense is that given? Do they have the reserve at that point to engage with that treatment? Or is the effect of the cancer on the body already so severe that we first have to focus on making them feel a bit better?
Well, I think we certainly have to focus on making all of them feel better, because yes, you're right, it might improve the resilience to receive further treatment, because we do know still, unfortunately, the majority of patients don't receive treatment for this condition, and that's a very big challenge, and that's why this is such an important topic. What I will say, because just I'm wrapping up in the last couple of minutes, is some really important things to highlight from this is that you should take it seriously. It's losing weight. It's a big deal, and we understand it. We get it. There are resources you can go to online from Pancreatic Cancer UK and other resources. Your clinical team, you bring it up to them. If you think you're worried about cachexia, please bring it up. It might not have been picked up, but maybe you're the first person to pick it up, and then make sure that people are taking it seriously. I think it's really important for the multidisciplinary team to kind of act on it and take it seriously as well. And I think that by kind of working together, the patient groups, the research groups, and we can see how broad the research aspects are. So I really hope that gives you a bit of hope that we are looking into it very seriously. We're going to try and make a difference